Diversity, Equity, and Inclusion Office, which consists of our DEI committee. I just want to welcome you to today's session. Our session is on LGBTQIA2S plus experiences in healthcare. And so I wanted to take a few moments to, in addition to welcoming you, let you know of some housekeeping. As has been advertised, we have ASL interpretation that's available for you, as well as what Joel put into the chat about closed captioning. If you are in need of that, just click on that. After today's session, know that you're going to receive an evaluation. We hope that you will take a moment to complete it and let us know what you'd like to see in the future so that we can plan throughout the year. Okay, so having said all of that, welcome again. And let me introduce you to the panel. Now, I don't think I see everybody, I'm not sure. But let me introduce you, and I'm hoping they will wave so that we can, what'd you say, Joe? CC should be available by clicking on an icon at the bottom left of your screen. We are also recording. So if you're uncomfortable being on camera, feel free to turn your camera off. Thank you so much, Joel, for that information. Again, I'm Betty Dennis, and I want to introduce you to our panel. Jazz McKinney. Jazz, okay, good, thank you. Jazz is the current executive director of the Grand Rapids Pride Center. I don't know if I see Thomas Pierce. Do I see Thomas Pierce?
I'm here. I joined.
Okay, wonderful, wonderful. Thomas was the director of the executive director of the Grand Rapids Pride Center, and now works with the DEI office at the University of Michigan Health West. Leslie Bacher. Okay, thank you so much. Leslie serves as the health coordinator for the Grand Rapids Pride Center and founder of the independent group Envy Social Club, which connects non-binary people in West Michigan. And Dr. Christy Vanderkalk, I know she is here. She is the program director for the WMU Homer Stryker, MD, School of Medicine, Department of Family and Community Medicine's Kalamazoo residency. Today, our session will be moderated by Dr. Pam Wadsworth. Pam, would you wave so everybody can see you? Okay. And if it's easier for you all, and it may be easier to switch the view so that you don't have everybody on the screen, feel free to do that. Dr. Wadsworth is going to moderate today, and she's an assistant professor in the Bronson School of Nursing here at WMU. So I, again, welcome you. I welcome the panelists. I am so appreciative of your time today, and I will turn it over to Dr. Wadsworth.
Hi, everyone. I'm so glad that we have 83 people here. It's super exciting. So quite an interest. My pronouns are she, her, and hers. I am going to start asking questions that were developed by the Diversity, Equity, and Inclusion group. So this was definitely a group effort. So my first question is, what are some critical things for students to know when serving this population?
Well, I like to say that it's not just good intentions, it's not just knowledge, it's not just effort, it has to be all of those things. We know, as LGBTQ plus people, that none of this is intuitive, and we all had to learn the terminology and the inclusion strategies ourselves at some point. For example, when I go out into the world, I know that not everybody knows what a pronoun is, and that's okay. But for me, pronouns are an important part of my gender expression. So I take it as part of my task to teach folks how to use they, them pronouns, gender neutral pronouns, and the pronouns of trans folks in general. But obviously, not every patient is going to be up for that. So, starting out by knowing how to use pronouns and having practiced them out loud is a really key piece of this. Just like calling someone by their name, the name that they want to be called, is a part of basic respect. The pronouns are a basic respect too. Just acknowledging folks as who they are authentically and not imposing one's own ideas about what they must be or stereotypes about gender onto them. Being ready for that interaction and already having the skill. Using they, them pronouns is pretty straightforward because we already do it in English. It's just a little bit more casual. For example, if someone has left a water bottle, we might say, oh, someone's left their water bottle. Do you think they'll come back for it? Even the most stickler person for grammar will acknowledge that it's probably just one person who left a water bottle, not 12 people that we're expecting to come back and scoop it up. Just like what I just said, we use plural helping verbs for they, them pronouns. So are and have, they are, they have, just like you would for plural you. So plural you and plural they, singular you and singular they, all work the same way grammatically. I could say, you are beautiful people, or you are a beautiful person. They are beautiful people, or they are a beautiful person. So the same way, the same verbs that you would use for a plural situation still work. When you're changing pronouns for someone in your head, it helps to adjust the way that you see them rather than trying to impose something else over them. So instead of looking at them and thinking, this is a woman, but I have to correct myself every time and say they, it's time to get at your own idea of what that person is, who that person really is, and see if you can change it from the inside of your own understanding of them. That's a bit high level, but it's still important stuff to know.
Leslie, thank you. That was beautiful. I know a lot of people talk about the grammatical, how tough that is, and the way you put it makes it so much easier. Thank you. Dr. Vanderklok, would you like to add anything?
Yeah, I want to, echo to some extent what Leslie said in that, good intentions are not enough, but they do count for something. And I think that as students, that it is our duty, our job as professionals, as students, as an attending physician like myself, to continue to educate ourselves so that our good intentions are as close as they can be with the knowledge that we have to the preferences of the people that we're serving. And, we can't rely on patients to teach us these things. yes, they can be our teachers and will be our teachers, but they can't be the only teacher. That is an undue burden for them. And so my encouragement for working with any population is to learn about them, to learn about that population, to learn about their culture, and preferences, and then also to recognize that everyone is an individual. And so not everyone is going to fit whatever mold it is that you've read about this particular culture. But people do recognize when you've put forth effort to include them, and will recognize those good intentions then, coupled with some knowledge.
Would it be all
Thank
right
you.
if I shared a couple of scripts since we were talking about pronouns? One is if you misgender someone, nobody's going to get angry and attack you. I promise that there won't be any. Probably they're more scared and worried in the position of being vulnerable and being misgendered than you are of misgendering them, although it is scary to do that, to call somebody pronouns or a name that they don't want to be called. If that happens, what you want to do is say, "Oh, I'm sorry," or if they have corrected you, "Oh, thank you." Say the thing again. Use the right pronouns this time, because that piece is so important. That is doing the work. That is showing that you care.
I'm just going to jump in here really quickly. I've gotten the pleasure to do a few of these with Leslie and Jazz in my time, so I'm glad to be doing it again with them. Usually when I'm doing this, I'm talking to either residents or physicians or some APPs, but I think this applies the same, and I always say the same thing. You want to, with any group that's different from you, so that's any culturally different group, and that can be across a lot of different demographic points, right? Um, Go into the room or go into the situation with a certain amount of humility, and I think humility goes a long way. Um, Being able to say, like Leslie scripted for us, um, you know, I'm going to learn this, right? Like if you're someone's therapist or you're their case manager or you're their supports coordinator, whatever role you end up in, I think someone said, it is our job to do self-education. We don't put that emotional labor on someone else, but it is okay to be like, I don't know enough about this right now, but I'm teaching myself, right? And I promise you, you'll go a lot further with that than you will by pretending you know, because most of the times people can pick up on that pretty quickly, that you actually don't know, and you probably end up doing more harm in the process. I always err on the side of I'm going to be a little humble and say I don't know, like I don't know. We always talk about consistently if someone comes out to you, right? Like that's a very trusting process. Someone must trust you a lot in order to do that, because there are a lot of safety pieces with coming out, right? Physical safety, emotional safety, psychological safety, all the safeties. And some folks are like, well, I have no idea what I would say, so then we tend to like get nervous, and then we start digging a hole of centering ourselves, when really it can be as simple as, if anyone listens to Brene Brown, thanks for telling me, like I don't know what you're going through, but thank you for trusting me enough to tell me, and then figure out what they need and help them find what they need. But I just always like to throw in there that I think humility goes a long way. And sometimes when we end up in positions where we are guiding someone or providing clinical services for someone, we feel like we have to have all the answers because people are coming to us, when that's not always the case.
Thank you so much. Thomas, Jess, do you have anything you'd like to add to this? No, you're good. Your baby is mesmerizing. I can't keep my eyes off them. So thanks for including them. All right. Well, let me
Pam, you muted yourself.
Thank you. Could you tell us experiences you've had with LGBTQIA2S plus patients? Good, bad, things you'd improve upon?
I think I'll take that one. Um, I think that so I am a mental health therapist by trade. Before I took over as ED of the Pride Center, so I actually used to work specifically with the LGBTQ population, um, and I think that general consensus was just a lot of lack of trust. It's very hard for people in underrepresented populations to trust because of how the system is set up and how the system is not made for us. Um, and so it's very hard for us to trust. And so that could include um, we may not come out to you for a long time. It may take us a while to come out. Um, it may take us a while for us to get to the root of whatever problem we're coming to you for. Um, you know, it's not as simple as like I would see a lot of people for depression, and it was like the root of the cause may have been, conflict within the family, but they would talk all around it, and I'm like, what, like what is really going on here? Like, you mean you're fighting over like peanut butter and jelly? Like, but it's like the peanut butter and jelly wasn't the problem, right? It was not talking about the root of the issue. And that happens a lot with patients as well, no matter what healthcare setting you're going into. Um, you have to kind of establish that trust and realize that we're the author of our own stories, but also there are things that you can do to try to help speed that trust along. So I talk about like in the healthcare setting, specifically like let's say like a hospital setting, you know, um, they can wear pronoun pins, um, or a rainbow badge or whatever it is, right? And one thing that we like to say, we being Leslie, um, is it also helps to introduce yourself using your pronouns. That's like one little way that we can like, okay, maybe this is somebody who gets it, right? So if you were to come to me and I'll pick on Leslie, right? So if Leslie were to come to me and say, "Hi, my name is Leslie. I use they them pronouns. How would you like me to address you?" That's one way that you're telling the community that you understand at least a basic knowledge of pronouns, which means that's one more step that we don't have to try to figure out. Because if I'm going to a therapist and I have to figure out, can I tell them that my pronouns are they, them? Are they going to attack me? Are they going to, I don't know, call me? So there's something going on in the community right now. I know I was talking with one of your fellow people about it, Rachel, where right now in Texas, they just signed a bill that basically said, you have to report a parent that supports their transgender kid. And you're reporting them for child abuse. Because if you allow your transgender kid to be trans, whatever that looks like for them, it's child abuse. Right? So imagine all the people in Texas now have to, like, if I tell them that my pronouns are they, them, like, I, I don't know what that could lead to, right? Or if I, refer to my child as, they, them, like their name is Sage, and I say, I tend to use they pronouns because I don't know what my child's gender is because they're not old enough to tell me. I could be charged with child abuse. So you have to realize that any person coming to you and you're in a position of power, being any sort of like figure, like a therapist or a doctor or anything like that, you have to realize you're catching us at some of our most vulnerable moments. And you have to understand that, and that's where Thomas speaks about coming into a situation humbly, because you should be honored that this person was able to trust you enough to come out to you about whatever it is. And I'll stop there so somebody else can talk.
Thank you. That was great.
I would say that every person on this call has had experiences in which they did not feel heard or seen. And I think if you reflect upon those experiences, you can recognize how uncomfortable a situation like that is. And so when I think about what interactions have gone well with the LGBTQ community and which ones haven't, that I think really is the dichotomy, is did the patient feel heard and seen? And if you recognize that medicine is built upon an extremely gender binary and heterosexist environment to begin with, then you need to also recognize that helping people who don't fit into those quote unquote norms be seen and heard and therefore comfortable takes extra effort.
Sorry, Leslie, were you going to say something?
I was just kind of going through it with this news about Texas.
Oh,
But I could say more things.
you're welcome.
Well,
with that.
I have something
Everyone, if
too
you're,
to add to that.
Go
oh,
ahead,
right,
Jess.
I'll be quiet. Yeah, great.
I was just going to say to add to what Christy was saying too was you have to also have a level of self-awareness, because the hard part, and I don't say this to scare anyone, but the hard part is if you do have a bad interaction, you may not know about it. Because like I had a bad interaction with an OB that was super just I don't even know what phobic he was, but he had a couple of them. And I just never went back. Right? So he could be thinking everything is peachy keen and not even realizing that he was harmful towards me. I mean, he probably knows because I actually made an actual formal complaint, so he probably knows. But a lot of times we don't have time to make formal complaints, right? Especially because that takes even more emotional labor from us. So I already had to deal with the emotional labor of being harmed by him. And now you want me to give you more emotional labor to make a complaint? Right? Because like we're used to people not listening to us. And so a lot of people won't even make a complaint because they don't think they'll be heard anyway. Right? Because I guarantee you, and not that I want this doctor fired, but I guarantee you he still works there. So what actually happened with my complaint? And how are they going to make sure that he doesn't harm other people like he harmed me? And the quick answer to that is right now, nothing, because he's still there, seeing patients just fine.
Yeah. I was rejected from care from primary care doctors. Not just the one doctor, but the entire office because of my queerness. And they wouldn't, not only would they not be reprimanded for that, because it was a mercy clinic, they might have been required. I don't know. or encouraged. I think that experience was tangled up with also disability and with my weight as well. So I'm going to drag the intersectional point into here because when we're looking for care, sometimes one side of ourselves would be safe and another side of ourselves would not be safe with a given provider. And the barriers that I have hit have almost all been more complicated than just one part of myself. That was a very frustrating time because I didn't have many other options, so I felt quite hopeless. But even more recently, when I have more social power to do something, I've faced being treated strangely for being trans in situations that you would not expect that to be the case. Like when I was getting top surgery, I was misgendered at least 20 times in a row by the nurse who was doing my intake. My mom was there advocating for me. And it took almost on the level of begging this person to stop calling me a pronoun that didn't apply. And so obviously because that's what I was there for. They ended up going out in the hallway for a while and came back and said, well, I've prayed about this in the hallway and I'm going to try harder. Like, oh, good. I guess that's better for me, but why did it take that? Why couldn't I just go there and already be safe? Because it was clear on all parts that that's what I was there for.
Leslie, thank you for sharing that. I'm so sorry. That is heartbreaking. And it kind of still leads to Jazz both spoke about this when Jazz said the doctor was phobic about something. Like, I don't even know what, like some kind of phobia. So they are intersecting and, and like you said, I'm going to intersectionality. So that's my next question. How do people deal with all the different marginalized identities that, stack up and intersect and make lives harder?
Well, I can tell you that word of mouth is really important for us. Even before I was in my current role as the health coordinator here at the Pride Center, I was helping my friends avoid a doctor who was known to be like overemphasis on diets and losing weight, despite being friendly to the community, because not all of us wanted to talk about diets and losing weight. There is a network of LGBTQ folks, and we talk to each other and try to guide each other, but we only have our own experiences to recommend off for the most part. So if there's somebody who has something that is outside of our own experience, they might still get stung. On a more professional level, we're trying to create a provider survey that captures that kind of information so that we can guide folks. But it still requires leaning on self-disclosure from the providers. And they don't always know that they're not accepting or affirming. sometimes they think, well, of course I wouldn't be rejecting that person. But then in the moment, they don't make the effort to use the pronouns because it doesn't seem urgent to them. Or whatever it is, whatever the piece is that is important to the patient but not the provider.
I think it's also important to understand of like going back to that education piece and like letting the client also help with that, right? Like there's a very, very thin line between letting the client educate you because you just aren't willing to do the work versus letting the client educate you about their individual self, right? Because I can tell you I'm a Black and Indigenous two-spirit individual, but what my experience as a Black person and my experience as an Indigenous person and my experience as a two-spirit person is different than another person who may be Black, Indigenous, and two-spirit, right? So I mean, I can tell you that yes, I've experienced some very stereotypical things as a Black person or an Indigenous person or a two-spirit slash trans person, um, but also allowing your patient to be their own advocate and write their own story, you know, because and you know, like that situation with the OB, you know, like I said, I don't know if he treated me horribly because I was Black. I don't know if he treated me horribly because I was a trans person that was pregnant, which is really rare in some people's minds. I don't know if it was because I was, you know, masculine looking. I don't know if it was because it was 5 o'clock in the evening. I don't know. You know, maybe he just had a bad day and he's an excellent doctor. I don't know, right? And I shouldn't have to find out either. He shouldn't have done it, and he shouldn't have said some of the things that he said, right? But it's just understanding and educating yourself and realizing where you're at. And you know, we don't expect you to literally know everything about everything, right? Like we don't expect that. That's impossible. But you should know enough about it, especially depending on where you're at, right? So like I know if um I don't know, if I work for a women's health center, I should at least be knowledgeable about women's health problems, right? Like you got to understand that and understand what's and then take the intersectionality piece, right? What's the difference between a white woman and her mortality rate in as far as childbirth versus a Black woman and her mortality rate versus in childbirth, right? So just understanding some of those different pieces.
Jazz, thank you. Thank you for sharing your experiences. What would you have wanted the OB to do? What could this person have done to mend that for you? I mean, after you reported and there was hopefully some awareness, maybe.
Yeah, that particular person, I don't know if there was a way to mend it because he literally left me to die. I did not have a great pregnancy. I was out all last year due to it. And if it wasn't for the fact that I had a friend who was an OB that told me that she was willing to take me on as her personal practice, I probably would have died because that OB essentially did not listen to any of my concerns. And the fact that I was in the hospital twice before I even saw that OB, and then proceeded to say, "You're hopeless. I'll see you in 2 weeks." And I probably wouldn't have made it those 2 weeks because he just did not listen to what I was telling him was going on with my body. However, for some people that do make mistakes, I think owning up to that mistake and learning and growing, I'm all about learning and growing, right? So if it was something simple like maybe he just didn't understand my history, right? Maybe he just didn't have time to read my chart beforehand. that's a, like, okay, cool, apologize, fix it, go read the chart. And he could have easily called me back, right? Like, I went into the office, this happened, and if he would have fixed it, he could have easily called me back the next day and said, you know what? I took some more time to think about it. I went and researched it. I apologize. Here's what we're going to do. Right? So sometimes it's just, again, humbling yourself and understanding that everybody can be wrong. But I think part of it was his ego didn't let him be wrong. And so he just left it at that. Right? Like, it didn't matter. He just left it at that.
It just seems like it so often falls on the population that's been insulted and been hurt to be the educators.
Yep.
And that is exhausting and frustrating, but how else do you make a difference sometimes, right? That's the hard part for me.
Yeah, absolutely. And that's what I said too, of like, it's so hard because it takes emotional labor to let a person know that something was wrong. And so sometimes having that self-awareness, right? Like, we all make mistakes, right? Like I just misgendered Leslie yesterday. We've been friends for years. Years. And I misgendered them yesterday, right? But all I had to do, stop, correct myself, and move on, right? Like, I apologized, corrected it, I moved on. And so did Leslie. Why? Because, again, Leslie knows that, like, clearly, it, like, I don't even know what happened, right? but it happens, right? And so it's like, but I had that self-awareness to realize what happened, and so I corrected it. I didn't put it on Leslie. It didn't take Leslie to be like, excuse me, Jazz. Like, it didn't take any of that, right? I realized I messed up, and I humbled myself and apologized to them.
Not everybody gets that right. I think occasionally we've got somebody who will deny, like, if they misgender me, they'll deny it right afterward because they don't want to have done it. But that it just comes across as gaslighting at that point, I did once have a pal who misgendered me in it was an LGBTQ space. It was in public though. It was in a hallway with a lot of other people. And when I let him know that he did, he dropped to his knees, he grabbed my legs, and he wailed, "I'm so sorry." I'm not friends with him anymore. Because he made it about himself. That's so unnecessary and so exhausting. It doesn't have to be a big deal.
I think there's this idea that if historically marginalized communities don't do the work, it's not going to get done. There is this idea that if we don't do it, no one else is going to do it. And I think that's a form of privilege that's being put on to marginalized communities. So when I started at UMH West, which it used to be Metro Health Hospital, my first project was to roll out our sexual orientation, gender identity data collection within EPIC, which is our electronic medical record. It was a very big project. And a lot of it, we had a lot of feedback, right? We got a lot of feedback. I'm going to call it feedback from employees, from patients. And then there was this conversation that happened once, and it was with our core SOGI leadership team. And it was, there's some folks from HR, there's project management, there's data analytics, there's our EPIC team. And there's this idea, and they were like, well, we don't know, and so if we don't know, how do you know, like, how are we supposed to learn? And I was like, well, you could Google anything almost, and then find out pretty quickly. But also, that's what my department does, like, that's part of my responsibility. But what it is, and I guess I'm talking from an organizational standpoint because that's the way I approach this from like a organizational theory kind of way. But it's not anyone's responsibility but the organizations. When talking about creating inclusive cultures. Yes, some of those folks that may identify in that community may choose to join you on that journey. They may choose not to. And usually, if they choose not to, it's because you haven't created a culture that they feel safe enough to do that. So they feel safe enough to be out and talking about their experience. And so then you have a culture of safety issue, which is much more than LGBTQIA plus issue. And I remember talking to some folks from HR and saying to them, and people from HR love me, and I love them too, but it's like I said, this is your responsibility, like it's my responsibility to partner with you on it, but it's your responsibility. So we got to figure out how to do this because it's not anyone else. Like they came here to work for us, like they're filling a need for us. Especially nowadays when you can't find many people that want to work in hospitals. And so I think I don't get stuck in the trap that like if you're part of some group that you are the target of an effort, of an inclusion effort, you are in no way required to join that inclusion effort. It may be helpful if you have the emotional bandwidth and knowledge and experience and you want to. That's great. But really, you chose them. Like you chose to work for them. This is a what is Michigan? What's it called? Like an at-will employer? Isn't that what people say?
Right to work.
And yeah, and you can go work for somewhere else, especially nowadays. You got options, and that's what I tell people. I did a presentation for a bunch of medical assistants a couple months ago, and I was like, if your organization doesn't have anything DEI related, a committee, a department, VP, or a director even, then and it's 2022, I'd start asking for one. And then you can let people know, just talking about MAs in particular, because they are in demand in healthcare settings. You can let them know I can go work for the next hospital, and I know they do. So you start leveraging the power that you have as an employee. But that does not mean you have to partake. And so I just don't want us to get into this idea of like it, because what I see it as, and this sounds really dramatic, but what I see it as is sometimes like this form of victim blaming, right? Like they don't participate, so
Mhm.
how will we know? Like if they don't come talk to us, how do we know? And if no one's coming to talk to you, again, it's because they don't feel safe enough to talk to you. You haven't made yourself safe enough, or your HR team, or your leadership team, or your director, whatever, however your organization's siphoned off, haven't created that culture of safety. So it's up to y'all to do the work, and it doesn't happen overnight. It's actually very slow, and can take years, and it just depends on what maybe has happened before, what leaders, what choices, whether it be good choices, bad choices, healthy choices, unhealthy choices, have been made in the past, because you might have some significant bridge building to do. Like Leslie, I'm just going to use your example because you were kind of open with it. I imagine that as famous as Leslie is in this community, and as wonderful as they are with public speaking, there's probably a good amount of LGBTQI plus folks that have an idea about mercy now, right? Like, and I don't say that as someone that works for another hospital. I just say that because that was the example. And so we stopped going to Mercy, right? Like we're not going to choose them. So if Mercy decides that they want to start building that bridge back, and I know a lot of great people that work at Mercy, they're going to have to do the work, but they probably have a lot of work to do, right? Not to mention they're a Catholic-owned institution, which also makes it hard. But just don't get stuck in a paradigm of you have to be part of the solution, just because you are the target of the effort. Because I think that's where we lead. That's where we get burnt out as. I'm just going to talk as queer people. That's where we get burnt out. Not to mention if you are representative of any kind of intersecting identity. So when we start thinking of queer people of color, trans people, queer people of color, when you start breaking down those or drilling down those intersectionality pieces, it can get very exhausting if you're the target of multiple different inclusion efforts. That was my soapbox for the last 5 minutes.
I love that soapbox. So I want to build off that, and so that the emotional work is not on LGBTQ people. I have two questions, and one is specifically for Dr. Vanderkolk, if what kind of training physicians get, and then also for the rest of you, if there are certain trainings that you would suggest that are available and around for future healthcare providers that we could take and do. But first, what kind of training do physicians get?
Not enough. So I would say that in the last decade, there has been quite a large push or movement, I guess, towards further educating physicians, or at least medical students and residents who are, going on to be physicians in some of these areas of intersectionality, trans care, sexual orientation, gender identity pieces, approaching patients in an open enough manner that they are free to be their authentic selves, those kinds of things. As part of that, it really sort of starts almost as a choice that as a medical student or a resident that you choose to acquire this extra or added in knowledge and information, as opposed to having it become integrated into the curriculum. And now that we're a couple decades in, we're seeing more and more integration into the curriculum. But there are studies of physicians and medical students that are less than 10 years old in which very explicitly people admit a bias towards trans people, like up to 40% of medical students I think in a 2010 survey said, that they would have some sort of negative reaction, I guess, to caring for trans persons. So I think that the movement is growing, but that there's a really long ways to go, and that with the way that medicine works, someone who is in their 60s right now, trained 40 years ago, and so there's a huge generation of physicians that got none of this education that are still very much in the workforce. And so that plays a role in things as well. But more specifically than things that I do, things that we are doing in the communities in which I personally work, doing some work around implicit bias, which I think has to be a part of this, and recognizing that this is a racist country and that this is a heterosexist country, and a gender binary country. And those of us who grew up here grew up in these sorts of environments where that culture is almost ingrained in us. And so this recognition that all of us have implicit biases and that all of them can play a role in any given interaction with a person who presents with us is so important. And then I do some studies, like research about integration of trans care into medical education and into residency education. And I do some education about care of genderqueer individuals in really early in the medical school career, and then later, and then into residency as well. And so, there are people who are doing the work. It's just a matter of making that work more generalized for everyone.
It's making DEI more than just a checkbox that organizations and educational entities check off, right? It becomes this thread that's infused just in everything we do. So yeah, we need to get there.
And something Leslie said that I can't stop thinking about, but or maybe it was Jazz actually, something that it wasn't a priority at the time to use pronouns. Like it always has to be the correct pronouns, right? Like it's not an extra like whipped cream kind of topping. Like it's care, right? So So are there specific trainings that you do suggest for us, or specific books, like, you know, healthcare students, people who are educating healthcare students?
We do some direct education to doctors or medical students. I was working with Spectrum for a couple of years, and part of their Healthy Pride group, and had the opportunity to speak to doctors there, as well as partnering with the MSU College of Human Medicine to do their resident panels. We do want to reach those groups, especially when they're still students, and especially when they're still open to hearing that they don't know everything yet.
I just want to clarify, we do trainings for everybody. So no matter what field you're in, and you know, whether it's social work or medical or anything like that, we do trainings for everybody. We can do group trainings. We stopped doing our individual trainings when COVID hit, but hopefully we get back to that where individual people can come do trainings with us. But yeah, so there's that. I would definitely say, I think Rachel has been putting in some links in the chat. There's the implicit bias test or assessments. I mean, there's all sorts of things out there that you could do. I would definitely look for things within the last 5 years, because as Christy was talking about doing research, the thing about research is you have to research the population to do the research. And trans people in particular have not been part of the research. You know, so we had a friend talking about, you know, how as far as HRT goes, taking progesterone long term, but there was a doctor that didn't want to prescribe progesterone long term because there was no research that said the effects that progesterone had long term. And it was like, yes, because you exclude us out of the research. But I will say, as we talk about, you know, the fact that we're the authors of our own story, that doesn't mean that we haven't done unofficial research. I guarantee you there are trans people that have done long-term studies on progesterone and how it affects you, but it's just not publicized because, again, we've been excluded out of the research. So just putting that out there as well of you know, the research has to include LGBT people in order for it to apply to LGBT people.
A couple of things that need to be covered, the bare minimum, I'd say, is practice using pronouns, not just spinning your wheels in your head, but saying it out loud and getting used to it and having that tool at the ready. Knowledge of barriers to healthcare that we face and community-specific health needs. So PrEP, hormone replacement therapy, those kinds of things. Even if a person is not a prescribing doctor and is in some sort of other field, you need to know what those things are and why we need them. And the knowledge of how to find more resources when needed. We have like 12, I think, social and support groups that are still running virtually at the Grand Rapids Pride Center. Everything from trans-specific teen group to a close-knit, which is the crafting group for the whole community, and men's group, women's group. One that's for trans and gender nonconforming people called Own Your Gender. We've got the resources are out there. One of our programs, I don't know, did I already talk about our therapy assistance program? We help pay for therapy for LGBTQ folks who are finding it to be a barrier. I'm going to drop a link in the chat here. One moment. Yes. But knowing where the resources are, yeah.
Thank you. I'm going to switch gears just in the last few minutes, if we can, and just to say, I've had a lot of students tell me this personally, and I'm wondering if you have advice. So students are, they're vulnerable, right, in the settings and medical settings, and do you have advice for them when they witness a conversation or treatment of an LGBTQ person? They just like they're getting a bad vibe, right? Like they're hearing heterosexist, homophobic stuff, transphobic stuff. Like, what advice can you give them?
Thomas, I think you answered this really well, so I think you should answer it.
Oh, I think he might be on the phone.
Did he drop off?
He's on the phone.
Oh, darn. Okay, that's okay. So I think that, so there's the term ally, right? Like most of us have heard about being an ally. Well, what we're leaning towards now is we want people to be, allies are good, but we want people to be accomplices with us. Part of being an accomplice is to almost put yourselves where we're at, right? So if we were in that particular situation, it could potentially be dangerous for us. An accomplice is willing to put themselves in that situation as well. And that's hard, right? But if I were to hear something like that, and I have to think about my physical safety, my emotional, my mental, all of that stuff, an accomplice is willing to put themselves. So speak up, right? Because you have that privilege, and it helps to take, and it lets people know that they're not alone. Because you never know who's listening, right? Like we have eyes and ears everywhere, surprisingly, but you never know who's listening. And so when I hear, I'll give you a very, very quick conversation. Is when I went to my new OB, the good OB, she was talking about my case in the hallway with her nurse, and her nurse accidentally misgendered me, and she corrected the nurse. Not me. I didn't have to like open the door and be like, hey, excuse me, say my pronouns, right? Like she corrected the nurse. She did that without even knowing that I was listening, right? She did that because it was the right thing to do, and she was able to be an accomplice towards with me and help to support me in that moment, even if I wasn't there. And that's the most important part is we should be doing this even if there's no one around that you think you're saving or whatever the word you want to use is.
Thank you. Anyone else in the last minute want to comment?
I guess I'll just add that for students, I know that there's so much concern about getting a poor evaluation or getting kicked out of school or getting a bad grade, not passing a rotation, all of these things. And I think that all of those things are important, but also should be recognized as a point of privilege that we all have by virtue of being in higher education. And I think that there are ways to tactfully go about this with your supervisors to avoid some of the negative reactions that you fear. And a lot of those can be learned through things like bystander training. And there are also ways to let the patient in that situation know that there is at least one person there who sees them. And whether that is public or private, I think, individual situations call for different things, but there are opportunities to help the patient be seen and also educate superiors.
Thank you so much. This has been a really great panel. Very educational.
Yeah, we are so appreciative of all of you. Thank you so much. You all are certainly welcome to use the reactions in the on WebEx and thank them, give them a hand clap, right? I just want you all to know how much you appreciate it. We need this information. We need to know how to work with everybody that we work with and make sure that everybody is seen. So we just want to say thank you from, as I said, the College of Health and Human Services. Thank you from the Diversity, Equity, and Inclusion Office, including our Dean, Ron Sisler, who unfortunately had a conflicting meeting at this time, and also our DEI committee. I do want to let you all know who our associate dean is, since she had an opportunity to say something, but I didn't recognize her at first. So Dr. Carla Chase, you want to wave? She had an opportunity to chime in. So I thank her as well for attending. And I thank all of you. Thank you, Dr. Wadsworth, for your time as well. And we will send out an evaluation. I hope you'll take a few seconds to complete that. And we'll see you at the next event. We will have our Berrien lecture in March, on March 24th. It'll be both live stream and in person in room 4010 of CHHS at 7 o'clock. And then March 25th is our DEI biennial conference, and that will go from 8:45 till about 1. So we hope to see you again. Enjoy the day.